Welcome to Rome. We're just entering the last session of an extraordinarily busy, eventful and hugely successful meeting on blood cancer in the elderly, the first ever ecancer symposium, and it has been a resounding success. We've had over 1,000 people here in Rome, and we have been covering all the issues to do with the elderly who are unfortunate enough to get a blood cancer of some description. And the whole thing can be summed up, I suppose, in one phrase, common phrase, maybe overused, and that's personalized medicine. The issues of the elderly start off with a definition. How old is elderly? I'm 66, am I elderly? The government thinks so, the bus services think so, the train people think so, and my insurance company thinks so. However, for the purpose of looking at elderly patients with malignant disease affecting the bone marrow or the lymphatics or whatever, the median age of most of these conditions is 70. So the agreement here was that elderly begins at 70. So I've got another 4 years to go. So that's good. So how do you attack this personalized medicine issue and bring age in to the equation? Well, of course, we always look at a patient's age. Doctor can't possibly miss it because it's plastered all over the front of the case sheet or up on the computer. But there is unquestionably evidence presented at this meeting of that being over-influential in a doctor's decision about how to personalize treatment further, and frequently, and all too frequently, the further treatment is no treatment. There's evidence which has really been devastating here that doctors are guilty of ageism. They are clearly deselecting patients from active treatment when there is active treatment available, which could prolong their life or maybe do even better than that and improve the quality of life too. So we have an issue, and that's what the conference was all about. So having taken the date of birth, there is a complete consensus across the conference that the biological age or the physiological age was the more important. Am I a fit 66 or am I a demented 66? And there are several assessment scores around, and there was a general agreement that none of them was yet perfect. Most people use the CGA, the general assessment, which geriatrics have been using for a long time, and most people thought that it was quite good but quite complicated and not disease specific. It didn't necessarily take care of all the kinds of comorbidities which patients over my age, at my age, may have. It was agreed that maybe a screening tool for each of the kinds of hematological malignancies might actually be a good way to go ahead while developing maybe more disease-specific versions of the CGA, the General Geriatric Assessment Tool. The agreement on the conference on the most important comorbidities were undiagnosed cardiology problems and undiagnosed kidney problems, both related to how you would eventually come down to choose treatment according to how the drug that you were selecting or the drugs you were selecting would be metabolized, excreted, and so on. That's just part of personalized medicine. We do that. It's just that we don't expect always to do a creatinine clearance in a patient before giving a treatment, whereas in patients over 70, we agree that we should be. There are other issues, of course, problems with the lungs and problems with the liver, but more commonly, we have to assess the cardiac status and assess the renal status. So the comorbidity issues are all built into the assessment tools that the geriatricians use. It's just that the oncologists don't use them very often, and quite often they don't understand what the geriatric assessment tools are all about. The bottom line, however, is that even in this elderly age group, even with all these comorbidities, it's most often the cancer that actually kills the patient. So we have to look at that as well. What kind of cancer is it? Has this particular 75-year-old got a smoldering myeloma? It's a term I understood today. A follicular lymphoma which doesn't need treatment for a while, or does it? A CLL, chronic lymphocytic leukemia, which can grumble along for 5 or 10 years, and do we need to treat it? And if so, with what? How can we change the course of the disease to inevitable crises later on? Then there was the management of the florid disease, or the aggressive lymphoma or leukemia arriving de novo. So the patient comes in the door with the aggressive lymphoma. There, again, there was a call for clinical trials. We need to have clinical trials on how to handle these issues in patients who are over the age of 70. And there are far too few. Very good evidence that the biology of these cancers, or the pathobiology of these cancers, does not change with age, except probably AML. There seemed to be a feeling that acute myeloid leukemia in the elderly was a different disease. But for the rest, multiple myelodysplastic syndrome, chronic lymphocytic leukemia, the lymphomas, myeloma, there didn't seem to be any hard evidence that this was a different disease over 70 to the disease at 69 years of age. Well, the evidence was produced in at least 3 or 4 of these subgroups of cancer that to give aggressive treatment at reduced doses actually did not always affect the outcome and could still produce a good outcome. And not only that, but in the period after achieving a good outcome, it seems as if maintenance of remission is becoming the norm rather than what for many years in my time was felt to be wrong. You took a patient with myeloma into remission and then stopped treatment. Well, the evidence is piling up now that suggests that you should be looking at maintaining patients because you continue to get people going into remissions late after the time when you'd generally stop treatment. The second important thing presented here was not just that you could achieve very good results in the elderly patient with reduced doses or altered schedules. Think of changing from bi-weekly to weekly bortezomib, for instance, and cutting down peripheral neuropathy. But also the massive opportunity is in the novel agents that are coming through. There's just no doubt whatsoever now that we've got some phenomenally interesting targeted agents, and targeted agents always go with personalized medicine, and these targeted agents are going to be supremely fitted for managing cancers in the elderly because they're frequently oral. We haven't discussed the compliance issue very much, but it doesn't seem to be a major issue. They're frequently able to be given at a distance, so the patient needs to back and forward to the hospital all the time. They are not nearly so hard on the patient who may have the comorbidities. They're not so cardiotoxic, or some of them aren't. They're not so renal toxic, some of them aren't. They're not so myelotoxic, some of them aren't. Many of them don't cause hair loss. And it might surprise you that even for elderly patients over the age of 70, 75, they still want to keep their hair. So all the way from assessing this personal approach to an individual patient by looking at the patient and the disease and then tailor-making the treatment, then the rest of the discussion is about support, all the other kinds of things that cancer patients need. They need them just as much in the elderly as they do in the younger group of patients: psychosocial support, social support, and in the elderly particularly support from caregivers. Now, there were 3 important omissions from this otherwise, I think, comprehensive conference. The first is that we didn't have any surveys to present about what patients felt the decision pathways should look like after the age of 70. And that's because I'm told that there aren't any. So we have to do something about that. We have to start bringing the patient into the discussion about what's the payoff between a certain kind of toxicity and a certain prolongation of life or chance of cure or something. Secondly, we didn't bring the caregivers in. And we did hear some case histories of patients who had been on treatments and the caregiver couldn't cope anymore. And the question is, how do you involve the whole family? It's a bit like pediatric oncology. You're not just dealing with the child with the cancer, you've also got to look after the siblings and the parents. Well, here you're talking about the grandmother or the grandfather with the cancer and the working daughter or sons or grandchildren in some situations have got to cope somehow or other, or else somebody else in the social community. And then the third thing, and the take-home message, if there's to be one, apart from treat every patient as an individual and apply personalized medicine, we need clinical trials. Poll after poll after poll throughout the last 18 hours or so of active meditation and thought, poll after poll has been saying that 70% of the audience of 1,000 or more were not putting patients into clinical trials. And so there were a lot of unanswered questions at the end of this conference, but at least we now know what they are, and we know that the way to solve them is clinical trials. And ecancer will be taking that forward, and we'll be facilitating the business of making patients aware that there are clinical trials and helping them get into them. Thank you.